it's Ralph again from Pathognomonic, and this is the third lecture in my series on immunology. This lecture and the next will deal with the adaptive immune system, which to reach its full potential begins with cell-mediated immunity. We left off last lecture talking about how dendritic cells kind of scout out the periphery and warn the body that it may be under attack, and they do this by traveling to nearby lymph nodes and activating lymphocytes. As we well know by now, TMB lymphocytes are the cells that control the adaptive response. While the term lymphocyte usually is used in reference to T and B cells, it also includes natural killer cells from the innate system. Lymphocytes normally make up about 30% of your circulating white blood cell differential. Lymphocytes are round, and the nucleus takes up the majority of the cell with a small amount of blue cytoplasm around it. This here could be a T cell or a B cell, and they can't be told apart under a microscope. Lymphocytes are the main cells seen on pathology in chronically inflamed tissue, which is what happens when something is triggering the immune system that can't be cleared. So this lecture is all about cell-mediated immunity and T cells. Let's dive into a little more detail. T cells represent most circulating lymphocytes and have several important surface receptors and cluster of differentiation molecules you should be aware of. Firstly, all T cells have a T cell receptor. This receptor can only bind one antigen, and as we learned in our introduction lecture, can recognize its antigen only once it is presented on an MHC molecule. And we also know that MHC can only present peptide antigen, meaning small protein molecules. And it is very important to make this connection for an understanding of immunology that T cells can only recognize and be activated by proteins. Polysaccharides, which exist in many bacterial capsules, are complex sugars and therefore cannot trigger T cells in cell-mediated immunity. This becomes important when we'll talk about the component particles used to produce vaccines. The T cell receptor has a bunch of diverse functions. Once the receptor binds its cognate antigen, naive T cells activate and become effector T cells. In addition to activation, though, the T cell receptor can also signal apoptosis or anergy when things go wrong. CD3 is a molecule bound to the T cell receptor and is responsible for signal transduction to the nucleus. The T cell receptor is kind of short and stubby, so signals must be communicated to the nucleus indirectly via CD3. And we talked about this in our introduction, but it's absolutely vital to know that the specific markers for helper T cells and cytotoxic T cells are CD4 and CD8, respectively. These are co-receptors which stabilize the T cell receptor MHC connection and are important for activation. The last one to know is CD28. CD28 is involved in T cell activation by antigen-presenting cells, which we'll talk more about later. So let's say this is a T cell. The T cell receptor has two chains and a binding region for its cognate antigen. Next to it is CD3, which helps transduce the signal to the nucleus. There will also be a co-receptor, either CD4 or 8, which helps the T cell receptor attach to MHC. While each type of T cell has different cytokines it can secrete, all T cells secrete IL-2, which is a growth factor for T cells, and we also saw in our innate immunity lecture that it can help stimulate natural killer cells. And T cells also release IL-3, which is responsible for the differentiation of stem cells in marrow, leading to the production of more immune cells. This is very similar to the function of GM-CSF, granulocyte macrophage colony stimulating factor, which is used clinically to aid white blood cell recovery in patients following chemotherapy or after a bone marrow transplant. T cells are produced in bone marrow as progenitor T cells, but mature into naive T cells in the thymus. It's easy to remember this because the T in T cells stands for thymic cell. The thymus is an encapsulated bilobed organ in the anterior mediastinum, and like we just said, it's the site of T cell maturation and differentiation. Histologically, the thymus has a cortex, which looks dense under a microscope and contains immature T cells. This is the cortex over here. The thymic medulla is more pale in appearance and is home to mature T cells. The medulla also contains structures called Hassel's corpuscles, which if you remember from microanatomy, look like little pink onions. These are concentric layers of epithelial reticular cells, cells that express a large part of our genome and present self-antigen to T cells to make sure they won't react to our own tissues. An important thing to note about the thymus is that old people should not have one. They start involuting around puberty and are pretty much non-existent by middle age. In a newborn, though, they're really large because they're working hard to graduate all these T cells. You'll see the classic thymic sail sign on a chest x-ray, which you should not confuse for a collapsed lung or a mass if they show you this picture. And you can see that it looks kind of like a sail in the right lung field. Let's talk about a disorder in which the thymus is not present and by extension T cells will not mature. This is DiGeorge syndrome, which is very testable. The pathogenesis of DiGeorge syndrome is a 22q11 microdeletion. Q represents the long arm of a chromosome, and here it's chromosome 22. And this leads to a lack of development of the third and fourth pharyngeal pouches. If you remember from embryology, the pharyngeal pouches are part of the branchial apparatus in the developing fetus and form the endodermal structures of the head and neck. These over here are the pharyngeal arches, and out here are the pharyngeal clefts. Inside, labeled 1, 2, 3, and 4, are the pharyngeal pouches. The third pouch contains the inferior parathyroid glands and the thymus. The fourth pouch contains the superior parathyroids and the ultimobranchial body, which forms the parafollicular C cells of the thyroid, which end up making calcitonin. The thymus ends up down in the chest, and it ends up pulling the inferior parathyroids down with it, which is how they end up lower than the superior ones. So once you know that it's a pharyngeal pouch problem, remembering the syndrome is pretty easy, but there's a great mnemonic for it as well. The mnemonic is catch 22. The 22 will help you remember that the deletion happens on chromosome 22. The C is for cleft palate, and the A is for abnormal facies. This is pretty non-specific, as many genetic syndromes cause some kind of facial deformity. The ones to hone in on to help you make a board's diagnosis is that T is for no thymus, since the third pouch is not developed, and in a newborn the thymic shadow will not be seen on a plain film of the chest. The second C is for cardiac abnormalities, specifically conotruncal heart defects, which are problems with the great vessels. Things like truncus arteriosus, for example, and especially tetralogy of Fallot. The aortic arches are the arteries of the branchial arches, so this kind of makes sense too. And lastly, the patient will have hypocalcemia because of parathyroid aplasia and the inability to regulate calcium. The passage may say something about tetany, perioral tingling, or something like that. Another pathologic finding is that in lymph nodes you will not see much paracortex, which is where T cells are found there. Examiners like testing this point because they want you to realize that if there are no mature T cells, any place where T cells are found will be underdeveloped. Lab findings will obviously represent a T cell deficiency, and you will get the types of infections that reflect this. Most DiGeorge patients are immunocompromised to some degree and will have problems fighting viruses and fungi. And they may also get recurrent sinopulmonary infections because we know T cell dysfunction directly affects B cell activation and function. But these patients generally do not get life-threatening opportunistic infection. If they have no parathyroid glands, they cannot make PTH, parathyroid hormone, which helps to absorb calcium from the diet and mobilize it from bone, so both PTH and calcium levels will be low. Lastly, there is a variant 22q11 deletion disease called velocardiofacial syndrome, in which you will get velum, that's the palate, heart, and face defects, but without the problems involving the pharyngeal pouch, so no hypocalcemia and no immunodeficiency. Let's talk about the process of maturation that T cells go through in the thymus. As we know, T cells are made in the bone marrow and then migrate to the thymus, and you should know that when T cells are first made, they are initially both CD4 and CD8 positive. The thymus, like we just saw, has two parts, the cortex and the medulla, and in order to mature, the T cell will have to pass two tests, one in each area. This immature T cell will enter the cortex and encounter self-MHC. This is the first test. If it can bind, it gets to live. Remember, T cells cannot recognize antigen that is not presented on MHC, so if it can't bind MHC molecules with at least some level of affinity, it doesn't even deserve to be a T cell. Again, we want MHC restriction in place to prevent autoimmunity. This process of T cell vetting that occurs in the cortex is called positive selection, and our body is saying, okay, you recognize MHC, now you get to be a T cell. At this point, differentiation into either a CD4 positive or CD8 positive T cell occurs, and expression of the other one is downregulated. On the other hand, if the T cell can't recognize MHC at all, it dies by apoptosis. If a T cell does make it through the first round of testing, it can move on to the second round in the medulla. Let's say it now becomes a CD4 positive helper T cell. In the medulla, the T cell is presented all kinds of self-antigen by those reticular cells of the Hassel's corpuscles we talked about. And this time, it's not supposed to recognize the antigen, and if it does and binds to it, it dies. And this is because we obviously don't want the immune system to be activated against ourselves. This process is known as negative selection. By the way, the antigen presented in the thymic medulla may include self-MHC, which is an antigen itself. So in order to function to begin with, T cells have to bind MHC, but they can't bind it with such high affinity to the point where they're recognizing it as foreign. If the T cell ignores the self-antigen, it will continue to live and go on to become a mature T cell. So positive selection happens in the cortex, negative selection happens in the medulla. And note that if you know where negative selection occurs, you also know where to find the Hassel's corpuscles, and vice versa. Now let's see this in the text. Like B cells, T cells are made in the marrow but go to the thymus to mature. In the cortex, you'll find T cells that are both CD4 and CD8 positive, and they like you to know this. Then what happens is positive selection, where the T cell receptor must be able to bind MHC, which is critical to its function, and if it does this, it can move on as either a CD4 or a CD8 positive cell. In the medulla, the T cell is presented self-antigen, but it should not bind this with any great affinity because that would lead to autoimmune disease, and if it does, it will die. This is negative selection. The way I keep positive and negative selection straight is like this. In positive selection, if the T cell binds, it's a good thing, but in negative selection, if it binds, it's a bad thing. And the way I remember that positive selection comes first is that in order to even be presented antigen by the reticular cells, T cells must first be able to bind MHC. The autoimmune regulator protein, or AIR, is a transcription factor in those medullary epithelial cells which helps express the self-antigen. And there's a disorder called autoimmune polyendocrine syndrome, which is what happens if someone is missing this protein. And the name tells you what happens. They get autoimmune disease of many endocrine organs. Common features include a triad of hypoparathyroidism, adrenocortical insufficiency, and this is one way to get chronic mucocutaneous candidiasis. You can also get other autoimmune problems like vitiligo, alopecia, and ectodermal dystrophy, which manifests as tooth, nail, and cornea abnormalities. If you see this on a test, and it's likely that you won't, not super high yield, then they'll probably make the endocrine dysfunction fairly obvious. Getting back to T-cell maturation, if it passes both tests, congratulations, it's good to go as a now mature but naive T-cell. Remember, lymphocytes only become quote-unquote educated when they meet their cognate antigen. And this entire process is called central tolerance to self, as opposed to peripheral tolerance, which happens in the bloodstream. Now that we have a pretty good understanding of T cells, let's harken back to where we left off in our last lecture. We talked a decent bit about the dendritic cell, whose job it is to alert the adaptive system that there's a big problem that the innate system can't handle, and it does this by antigen presentation. We saw how antigen is sampled and processed and how dendritic cells can migrate to a draining lymph node where they'll encounter helper T cells. Well, we're now going to see how dendritic cells and other antigen presenting cells activate those T cells. For an antigen-presenting cell to activate a T cell, it must send two signals. Let me demonstrate this with a schematic. Here's an antigen-presenting cell. And the first signal is the actual presentation of the antigen itself on MHC class 2. Let me write in MHC class 2, and let's make it holding out some kind of antigen. When it passes a helper T cell, the T cell receptor can recognize the antigen as being its cognate antigen and binds to it with its associated CD4 molecule stabilizing the connection to MHC2. These three together, the T cell receptor, its co-receptor, and MHC, form what is called the immunological synapse, and this is the activation signal. After activation, the T cell still requires a co-stimulatory proliferation and survival signal. This second signal occurs when B7, which is part CD80, part CD86 on the antigen-presenting cell, binds to CD28 on T cells. Only an antigen-presenting cell can provide both signals, and it's like two-step verification, just to be sure that an immune response is warranted. And this is yet another mechanism to prevent immune overreactivity and autoimmune disease. Once fully activated, the T cell can now proliferate. The caveat here is that it is possible for an antigen to cause MHC binding in a non-specific way to just any T cell receptor. An antigen that can do this is called a superantigen, and it can cause polyclonal proliferation of T cells, leading to a massive release of cytokines, mainly interferon gamma. This is a big problem because interferon gamma will stimulate macrophages to produce tumor necrosis factor, which we know causes vasodilation and shock. The classic example of a superantigen is TSST1, which is the toxic shock syndrome toxin made by Staph aureus. Cytotoxic T-cells are also activated by binding their cognate antigen, only it will be presented on MHC class I by just ordinary tissue cells, and the co-receptor, as we know, is CD8. The big difference is that the second signal for cytotoxic cells is the presence of IL-2, secreted by helper T-cells, so cytotoxic T-cells can only be activated once cell-mediated immunity is in effect. What happens if a T-cell doesn't receive a second signal? Anergy, that's what happens. Anergy is a state where a T-cell can no longer be activated by its antigen at all. Again, this happens if a T-cell meets its antigen but there fails to be a second signal from an antigen-presenting cell. This is a mechanism of peripheral tolerance to self because it happens in the blood after T-cells have graduated the thymus. I think of anergic cells as kind of the opposite of memory cells. We don't want accidental signals triggering T-cells that somehow made it through the thymus recognizing self-antigen. These cells lose all activation privileges and are quote-unquote forgotten, so they can't trigger autoimmunity. Another method of peripheral tolerance is clonal deletion. This is similar to what happens in the thymus. When any T-cell is activated, it starts expressing Fas ligand, which is part of the apoptosis pathway and which can cause apoptosis of the T-cell itself or lymphocytes around it if it's activated in the presence of self-antigen. This is also called activation-induced cell death and is one of the reasons why mutations in Fas or Fas ligand can lead to autoimmune disease such as lupus, because these self-reactive cells fail to kill themselves. So mature T-cells become either cytotoxic or helper T-cells in the thymus. There's a lot more to know about helper T-cells, and there are different subtypes within the helper T-cell category. So let's talk more about their role in the adaptive response. Just a reminder that all helper T-cells we are about to discuss are CD4 positive. This means they bind MHC2, which means they are activated by antigen-presenting cells, and as we know, this is most easily carried out by dendritic cells in lymphatic tissue. And as we discussed in our introductory lecture, helper T-cells on their own don't do much. Rather, they help other cells either within the lymphatic system or at the site of infection, and they do this by releasing cytokines. Here are some cells helper T-cells help to activate. One of the functions of helper T-cells is upregulating antigen presentation, which amplifies the adaptive response, and it kind of feeds off of itself. Whether it's a dendritic cell, macrophage, or B cell, the activation of antigen-presenting cells requires the binding of CD40 ligand on T cells to the molecule CD40, which we have noted is on all antigen-presenting cells. Helper T cells can also help out at the site of infection by stimulating cells such as macrophages, leading to better phagocytosis, or natural killer cells to help kill virus-infected cells. And they can activate cytotoxic T cells in the case of a bad viral attack. Helper T cells can also travel from lymph node to lymph node, activating B cells to become plasma cells, and lead to more effective antibody production by inducing class switching to different types of antibody. Like we just mentioned, within the category of helper T cells, there are several subtypes that are important to know about, and the kinds of helper T cells that are made will depend on the particular infection and the response that is needed to fight it. Keep in mind that these subsets of T cells are not really well defined, but for ease of discussion they are separated into distinct categories, and this is based on the conglomeration of cytokines that they produce. And it is also cytokines, of course, secreted by cells of the innate system and by helper T cells themselves that determine which kinds of helper T cells differentiate and really dominate the response. IL-12 is one of the cytokines released by macrophages we talked about back in our innate immunity lecture, and together with interferon gamma, secreted by natural killer cells, produces a Th1 predominant response. Importantly, Th1 cells themselves secrete interferon gamma to promote their own differentiation in an autocrine fashion. IL-2 is a nonspecific growth factor for immune cells, so I'm not sure it would be tested, but for sure know that IL-4 stimulates a Th2 response, and is secreted by Th2 cells themselves, again, to stimulate their own production. Transforming growth factor beta stimulates the production of regulatory T cells, also known as Tregs. TGF-beta is a cytokine secreted by macrophages, which we have not discussed yet, and also by Tregs themselves. Take a second to notice that all of these cells stimulate their own production. Let me take a second to talk about TGF-beta because we haven't yet. The general effect of TGF-beta is context-dependent, and it has some pro-inflammatory effects. But for the most part, you should think of it as a cytokine that downregulates the immune system, and it is involved in apoptosis. Contrary to its name, TGF-beta has a growth inhibition effect, and it correlates with malignancy when cells stop responding to it. Unfortunately, in these situations, its immunosuppressive function then dominates, causing growth, which continues undetected and unchecked by the immune system. And you probably won't be tested on this, but here for completeness is that IL-6 produced in acute inflammation causes a Th17 response. Each of these helper cell subtypes has a unique role and predominates in certain types of infections. We'll discuss them individually now and talk about the cytokines they produce to carry out their roles, starting with Th1 cells. Rather than just focusing on the details, I want you to take note of the broad specialty of these cells because it will help you remember the cytokines they produce and what those cytokines do. And the job of Th1 cells is to help the innate system take on intracellular pathogens. Some bacteria, for example TB, can hide inside cells, so an antibody response won't do too much and is inappropriate. And we already know that we need a cell-mediated response and cytotoxic cells to help out with viruses that infect cells. So which cytokines can help stimulate the right response in these circumstances? Firstly, and most high yield, you should know that Th1 cells secrete interferon gamma. We already saw in our innate immunity lecture that interferon gamma stimulates macrophages to enhance their phagocytic killing by becoming epithelioid histiocytes and forming granulomas. And now it makes sense that Th1 cell differentiation happens in response to macrophage-produced IL-12. And it's important to tie all this together for the boards because tuberculosis is high yield and examiners like you to know how the body handles it. And you now know that the stimulus for granuloma formation in TB infection is largely Th1 mediated. When a macrophage is infected with TB, which we will make carbofuscin colored, the macrophage will secrete IL-12, which will send helper T cells down the Th1 pathway of differentiation. Th1 cells, like we just said, secrete interferon gamma, which activates the macrophage, enhances phagocytosis, and stimulates the macrophage to make tumor necrosis factor. And as we know, tumor necrosis factor is responsible for granuloma formation to wall off the infection in a fibrous capsule, resulting in the latent stage of TB. Interferon gamma also enhances antigen presentation by increasing MHC on all cells, and this allows intracellular pathogens to be detected. It also leads to some IgG production, which we will learn opsonizes bugs to aid phagocytosis. IL-2 is a pretty general cytokine, but is especially secreted by Th1 cells. We saw a few slides ago that IL-2 is a requirement for the activation of cytotoxic T-cells as a second signal, and we already know that it's a growth factor for all T-cells and natural killer cells, which as we have said are basically the cytotoxic T-cells of the innate system. So all of this again fits our overall narrative of Th1 cells triggering a cell-mediated response against intracellular pathogens. Since each type of helper T cell is only necessary for specific kinds of infections, they get inhibited by the cytokines secreted by the other subtypes. Th1 is inhibited by IL-4, which is made by Th2, and IL-10 is made by Th2 and Tregs, and is a general anti-inflammatory cytokine. Since interferon gamma helps form granulomas, without it, someone can get a rare susceptibility to mycobacterial disease, especially TB. And it may actually be caused by not only genetic defects in interferon gamma, but also the interferon gamma receptor. IL-12 receptor deficiency is a variation of the same disorder. Since IL-12 is needed to stimulate a Th1 response, there will be less interferon gamma produced and the result is the same. The way this disorder usually comes to light is when there is disseminated fungal or mycobacterial disease in a child who has just received the BCG vaccine, which is a live attenuated mycobacterium and is mainly administered in countries where TB is endemic. An infant might present after being injected, having nonspecific symptoms, develop recurrent respiratory infections, and a blood culture will grow the bug. The treatment is to give back interferon gamma, unless it's the interferon gamma receptor that's the problem, in which case only a stem cell transplant would help. Let's compare this with Th2 cells, which you should associate with the fight against extracellular pathogens and humoral immunity. And the reason these two go together is because you need antibody to neutralize pathogens, preventing them from entering cells to begin with, and to opsonize them for phagocytosis. Antibodies also help kill parasites, which are too big for phagocytosis. And of course, Th2 cells manage these situations using their specific set of cytokines. IL-4 promotes B-cell growth and antibody class switching to produce IgE, and also some IgG antibody. Since IL-4 and interferon gamma both play a role in class switching to IgG, it's probably not something you'll be tested on. Examiners will go after IgE though. IL-5 is another cytokine secreted by Th2 cells, and it promotes eosinophil growth and class switching to IgA. IgA protects against gut infections, including parasites. Again, since Th2 cells help guide the immune system toward fighting extracellular pathogens, it makes sense for their cytokines to affect eosinophils and IgE, which are both instrumental in fighting parasites. IL-10 is an anti-inflammatory cytokine, and a way to remember this is that it attenuates the immune response. It does this by lowering the expression of MHC class II. IL-10 also inhibits the Th1 subtype and inhibits macrophages. For example, in Crohn's disease flares, a Th1 response activates macrophages which form non-caseating granulomas and cause epithelial cell death in the GI tract. When disease is remitting, Th2 cells are more prominent and IL-10 is the protective cytokine. IL-13 is low yield and is fairly similar to IL-4, but is thought to have a larger role in allergic reactions. And just like Th1 cells are inhibited by the Th2 cytokines, IL-4 and IL-10, Th2 cells are inhibited by interferon gamma, a Th1 cytokine. Now that we've covered most of the interleukins, let's do a quick recap using a pretty decent first aid mnemonic which covers the first 6. The mnemonic is hot T-bone steak, but you kind of have to remember what's being emphasized. The word hot goes with IL-1 to help you recall that it causes fever. The T is for the fact that IL-2 stimulates T cells and IL-3 stimulates bone marrow. That's what the bone is for. And then you just have to ignore the next couple of letters before you get to the real reason I like this mnemonic, which is because I just have to remember the steak part and that E comes before A, and it helps me keep straight that IL-4 is for class switching to IgE and IL-5 is for IgA. And lastly, IL-6 is for acute phase reactant production. If you take the second letter of the word acute, only misspelled with a K, which is pretty lame. And other high-yield ones to know are IL-8, which recruits neutrophils, and neutrophils eat stuff, so maybe eat 8, I don't know. And also IL-10, which we just saw as an anti-inflammatory cytokine and attenuates the response. Th17 is pretty low yield because it's not very well understood. But it's better than Th2 against some extracellular bacteria and fungi, and this is because it recruits neutrophils. It's also associated with mucosal immunity. And its primary cytokine is IL-17, which is how it got its name and makes it pretty easy to remember. It also releases some other cytokines which you probably shouldn't spend any time memorizing. Chronic mucocutaneous candidiasis is a heterogeneous disorder with a wide range of causes, including mutation to the AIR protein, which we touched on previously. But if it comes up on a test, think about a defect in IL-17. The Candida species of fungi are extracellular, and T cells play a role in their clearance in the periphery, apparently by signaling to neutrophils to enter the tissue. Without IL-17 signaling, repeated infections can occur. And remember that since this is a T cell abnormality, it will manifest as non-invasive mucosal Candida infection only, like oral thrush or vulvovaginitis. Neutrophils are still there to protect us against disseminated Candida. If a patient has a problem handling Candida and recurrent infections, one way to test for peripheral immunity is the Candida antigen skin test. There won't be any response, and there's also an in vitro test that can be done as well. And like the others, Th17 cells are inhibited by other helper T cells, Both Th1 and Th2 cytokines inhibit Th17 differentiation because we don't really need Th17 around for most infections. The only reason you may need to know about Th17 cells is because of hyper-IgE syndrome, which sounds more like it would be associated with a B-cell abnormality similar to hyper-IgM, and that's why I like to remember it by its eponym, Job syndrome. Job syndrome is caused by a dominant mutation in the signal transducer and activator of transcription 3 of the JAK-STAT signal transduction pathway. In other words, some disrupted intracellular mechanism causes a problem with Th17 differentiation. One thing we know about Th17 cells is that they recruit neutrophils to tissues, and this is at issue in this disease. A good mnemonic to help you remember the syndrome is fate. This syndrome got its name because the biblical character Job was afflicted with terrible skin lesions, a part of this condition, and since Job was always being tested by God, one may say this was his fate. The F is for facial dysmorphia, which can make people with Job syndrome look more like each other than their own families. The A is for abscesses. People with this disease get skin and sinopulmonary infections. These will be quote-unquote cold abscesses because there are fewer neutrophils in the periphery and less acute inflammatory cytokine production. Patients can be infected but report feeling well. This is similar to what we saw in leukocyte adhesion deficiency, except there the exam will stress lack of pus, and here there is a lack of inflammation. Another difference is that in leukocyte adhesion deficiency, the umbilical cord is retained. In Job syndrome, patients retain their primary teeth, and the T is for teeth. So if you see a passage that says something about 2 rows of teeth, bingo. On the boards, that's Job syndrome. The E is for eczematous dermatitis, which they will get without any other signs of atopy in the first few weeks of life. The rash will be intensely itchy due to the release of histamine from all the IgE and also eosinophilia in the skin. The elevated IgE is actually an associated abnormality, the result of the dysregulation of helper T-cell differentiation. It's not too involved in the pathogenesis of the disorder, but if there's an isolated elevation in IgE in an immunodeficiency question, think about Job syndrome. A variant of helper T-cells, regulatory T-cells, or Tregs, are what they sound like. They're responsible for regulating the immune response and maintaining the peripheral tolerance of all other T-cells to self-antigen. This is super important when it comes to preventing autoimmune disease. The special surface marker for Tregs in addition to CD4 is CD25. CD25 is actually the IL-2 receptor, and so it makes sense that IL-2 receptor polymorphisms can cause autoimmune diseases such as multiple sclerosis and type 1 diabetes. Tregs also express a molecule called CTLA4, which helps them get rid of self-reactive T cells. CTLA4 works by competing with B7 for CD28, inhibiting the second signal for T cells and thereby causing T cell anergy. Since this is an anti-inflammatory cell, it produces anti-inflammatory cytokines, IL-10 and TGF-beta, both of which inhibit antigen presentation. And it should also come as no surprise that Tregs are inhibited by IL-6, a very pro-inflammatory cytokine. The last thing to know for Tregs is that they express a protein called FOXP3, which is called the master regulator and is responsible for Treg development and maintenance. And because every random protein we bring up has an associated syndrome, what happens if someone is missing this protein is that they'll get IPEX, which stands for immune dysregulation, polyendocrinopathy, enteropathy, X-linked. If anything about this is tested, it will most likely be the genetics, which we said is a FOXP3 mutation on the X chromosome, and also remember the association with Tregs. As for the syndrome, the name pretty much says it all. It will manifest as autoimmune disease involving endocrine organs and a potentially life-threatening chronic diarrhea. People with this disorder can also get autoimmune skin stuff, nail dystrophy, dermatitis, etc., and this syndrome actually sounds a lot like autoimmune polyendocrine syndrome. The truth is there is a lot of overlap, which is maybe why they're both not tested that often. One thing that can possibly distinguish IPEX, however, is the type of endocrine dysfunction. IPEX can present as type 1 diabetes or autoimmune thyroiditis in a newborn, which is otherwise pretty rare. Brief summary of helper T cells, since there are a lot of different cytokines to remember. It's helpful to recall that all helper T cells secrete cytokines that lead to their own proliferation, and this allows the type needed for a certain infection to be made preferentially in a positive feedback loop. Each helper T cell also produces cytokines that shut down production of the other subtypes, and this happens locally because cytokines don't travel too far. So here are our 4 types of helper T cells: Th1, Th2, Th17, and the Tregs. Macrophages secrete IL-12, which leads to the differentiation of Th1 cells. Th1 produces interferon gamma, which has a positive feedback effect on the production of more Th1 cells. You are also well aware by now that interferon gamma stimulates macrophages. Th1 cells also produce IL-2, which activates cytotoxic T-cells and natural killer cells. Remember, this is to take care of intracellular pathogens. IL-2 also stimulates Th2 cells, which go on to produce interleukin-4. IL-4 has a positive feedback effect on Th2, as well as stimulates B cells to switch to IgE production. A second Th2 cytokine, IL-5, stimulates B cells to make IgA. And lastly, Th2 cells make IL-10, which we'll keep in our back pocket for a second. We know from our innate immunity lecture that macrophages make IL-6, and this causes the production of Th17 cells. Th17 is easy because it secretes IL-17, which recruits neutrophils in acute inflammation. And our last cell here, the Treg, also secretes IL-10 in addition to TGF-beta. First of all, TGF-beta has a positive feedback effect on its own production by stimulating Tregs. And keep in mind, macrophages make some TGF-beta as well. TGF-beta and IL-10 are both anti-inflammatory cytokines, and they work by shutting down antigen presentation, so we'll show them both inhibiting this dendritic cell. IL-10 also inhibits Th1 cells, as well as macrophages. And remember, all the helper T cells inhibit production of the other types. So interferon gamma inhibits Th2 and Th17 cells. IL-4 inhibits Th1 and Th17 cells, and something has to inhibit the anti-inflammatory Tregs, and that's IL-6, a very pro-inflammatory cytokine. So helper T cells have kind of dominated the discussion so far because there are so many different kinds. But let's talk for a minute about the other major type of T cell, the cytotoxic T cell. Cytotoxic T cells, as we've recently learned, are activated by Th1 helper T cells. And we've also already established that they're CD8 positive. And they use CD8 to help them bind to MHC class I on virus-infected cells. If they recognize a viral antigen as their cognate antigen, they kill that cell. Just like natural killer cells, cytotoxic T cells use perforin and granzyme B to carry out this killing. So let's say this is a cell infected with some kind of virus, and inside the cell, the virus is protected from antigen-presenting cells, and antibody can't get to it either. Luckily, one of its viral buddies has already been presented to a helper T cell, which has activated a cytotoxic T cell. The cell being attacked can present the virus to the cytotoxic T cell on MHC class I, and the cytotoxic cell can then kill the infected cell using the enzyme perforin to make holes in it. This is followed closely by granzyme, these orange dots in our diagram, which induces apoptosis intracellularly. Another way cytotoxic T cells can induce apoptosis is through the Fas pathway. The membranes of cytotoxic T cells contain Fas ligand. Fas is the CD95 death receptor on cell surfaces, and which I'm drawing into our diagram here, and its ligand binding triggers the extrinsic pathway of apoptosis and kills the cell, and this mechanism is shared by natural killer cells as well. Cytotoxic T cells are also involved in peripheral tolerance and kill overreactive lymphocytes by apoptosis. When this pathway is not intact, the consequence is autoimmune lymphoproliferative syndrome. It's usually caused by some mutation involving the interaction between Fas and Fas ligand, but it can also be due to a defect in caspase-10, an important intracellular protein in this pathway. The effect is unchecked self-reactive lymphocytes, which can mount an immune response against antigens in the blood, causing anemia and thrombocytopenia. Proliferation of these overactive lymphocytes can cause generalized lymphadenopathy and hepatosplenomegaly, which can eventually turn into lymphoma. Cytotoxic T-cells can recognize all kinds of foreign tissue, not just viruses. They're the main cell involved in chronic rejection of transplanted tissue, and they're also involved in killing tumor cells. Some cancers can avoid detection by cytotoxic T-cells. PD-1 is the programmed death receptor on activated T-cells, and these tumors express the ligand that binds this receptor. This inhibits the T-cell response and allows the tumor to evade the immune system. There are monoclonal antibodies being created to block these receptors so that cytotoxic lymphocytes can get on with cancer cell apoptosis. Let's quickly recap what we've learned in this lecture about cell-mediated immunity. We learned that T-cells undergo both positive and negative selection as they mature in the thymus and become either helper or cytotoxic T-cells. Helper T-cells are activated when extracellular antigen is presented by antigen-presenting cells, and we know this is done by MHC class II binding CD4. T-cells activated without a second signal undergo anergy, and this is a mechanism of peripheral tolerance. Once activated, helper T-cells proliferate and produce their own specific mixture of cytokines tailored to what the infection is. Th1 cells stimulate macrophages, natural killer cells, and cytotoxic T-cells to kill intracellular pathogens. Some of those intracellular pathogens are viruses, which the cytotoxic T-cells can take care of by inducing apoptosis of the host cell. Don't forget they can also kill tumor cells and the cells of transplanted organs. Th2 cells activate B cells to attack extracellular pathogens using antibody. And lastly, Tregs secrete anti-inflammatory cytokines and are important for tolerance to self-antigen. And that's cell-mediated immunity in a nutshell, but be sure to check out the other pathognomonic videos covering board's immunology. In our next video, we'll wrap up our tour through the immune system by discussing everything antibody and going through the histology of the remaining immune organs. If you like this video, share with your classmates and friends, give it a big thumbs up, and hit the pathognomonic icon to subscribe to the channel. And we'll be coming out with more videos on other high-yield boards topics, so ring the bell if you'd like notifications. And as always, please leave your comments below and tell us what we're doing well and where we can improve. Thanks for watching, and I'll see you next time.